Okay, so pancreatitis. Again, kind of like with the liver, think about what the pancreas does, part of the your like intestines, how it reacts with them, and then think about how it could be not working, why it's not working, how to treat it, stuff like that. So it does the exocrine and the endocrine. So exocrine would be those enzymes breaking down digestion, starches, proteins, fats, looking at your amylase, lipase, all your labs, and then the endocrine, the glucose part. It regulates your glucose. You got alpha cells for glucose and beta cells for insulin. So she has here a picture, and your gallbladder, because it's so close, I have it circled, and it could cause pancreatitis. If like you have gallstones and something's backing up, think about something's backing up this way, it'll back up the whole system. So it could cause an inflammation of your pancreas as well. Again, it moves backwards, the enzymes, and then the enzymes themselves are meant to break stuff down. Like lipase, all your enzymes are made to break down food. So if they're released and it's a good stream and they go and they break down your food, great. But if it's released and something's blocking it or it's not being able to get out of the pancreas, it will digest the pancreas. It will literally break down the pancreas, and it's horrible. It can be a good prognosis if it's caused by like an obstruction. You remove the obstruction, everything's fine. It can be a poor one, alcoholism. Alcohol affects a lot of things, but your liver and your pancreas especially is one of them. The mortality is over 60% if there is tissue destruction. Kind of like I said, if it starts breaking down that pancreas, that's destruction, and it's not a good outcome. And then also pancreatic cancer can be high as well. So acute inflammation, it can be a life-threatening inflammation of the pancreas. Happens really quick. There's an obstruction that builds. Finally, it builds so much that nothing can get through. You can go in and put a stent in, stuff like that. And then if it's continuous damage, because if it's like edema, inflammation, severe, okay. So when it releases the enzymes, it says that it can destroy the pancreatic cells because it auto-digests itself, kind of like I just mentioned. And then if it is continuing to happen and it keeps breaking down its cells, then it goes into the necrotizing hemorrhagic pancreatitis. And that's the NPH, and that will make your pancreatic tissue is dead. It'll make you bleed a lot, and then it'll cause tissue death and then shock, and then you could even die from it. How does this happen? So the exocrine glands are released for digestion. Like I said, they're released to digest foods, and if it's not going to the food to digest it, it's going to break down its own self, the pancreas. It should be going into the small intestine, and then it's when the enzymes are activated early or they're not getting to the small intestines, then it's going to break down itself. Direct injury to the pancreatic cells, and then duct obstruction. So that's when some people have tumors there. I know my grandma had a tumor, and it was blocking liver and pancreas because they go into that common duct. There was a tumor there, and then nothing was getting excreted. She was very jaundiced, itchy, stuff like that. So if there's a tumor or another kind of obstruction, that will lead to autoingestion of the pancreas because it's not getting to where it needs to go. It's backing up. So for processes, so there's your lipase. That is when the fat necrosis. Okay, so there's four processes of acute pancreatitis. So your lipase is released, and that can cause the fat necrosis of the pancreatic cells. So fatty acids are released, and then the combination of acid is formed. It's like a soap-like product. Don't worry about that. Just think of like what lipase is supposed to do. It's supposed to break down those fat cells, and when it doesn't get there, it is deadly. And then it says rapid loss of calcium because it combines to calcium. So when you're not releasing it, it's going to bind with calcium. If it doesn't get to break down that food, it combines with calcium. And then once you are hypocalcemic, that's deadly. Then the next stage, it just says breaking down the proteins. We know that it breaks down proteins. And then necrosis, so that trypsin and a lactase release. I can't say it. You all know I can't say words. The ducts, and then the blood vessels dissolve, and then that causes bleeding. If like your pancreas is very vascular, it's in your abdominal cavity. Your aorta runs off into it. So if you're breaking down all the cells around that vessel and it gets to the vessel and it breaks down the vessels, it's going to just be massively bleeding. A way that happens, it just explains vasodilation and increased vascular permeability. It's going into the third spacing. You're losing it. So in fifth semester, you learn about distributive shock. It's distributing, going outward, and it's not coming back. So hypovolemia, shock, and then death. Inflammation is where the leukocytes gather around the damaged tissues, and then inflammation forms. So if it's already bad enough that your pancreas isn't working right, let's add some edema and inflammation and just swell the area, because that's going to help. So look at your different muscles, the spastic muscles down there. The bleeding will just phase, it just keeps bleeding. And then there's another thing here. It just says it'll form little clots, but massive hemorrhaging, kind of like DIC. So you're bleeding, you're bleeding. It's going to try and clot off all these little things. And then you're going to use all your clotting factors, and then it's just going to keep massively bleeding. Just like this picture. So you're going to have weeping. You're going to try and clot it off. It's not really going to work. You're going to have clots. So then your body thinks, I need to dissolve those clots. And then you're just going to bleed out. Complications would be that hemorrhage, because you're having decreased perfusion. You can have pulmonary failure, because when your pancreatic enzymes, it's directly below that diaphragm. So when you have an increase of all that stuff right there, it can kind of go up into the diaphragm and then above it. So then it'll cause your perfusion. Do you learn about our acute respiratory distress syndrome? You learn about that in fifth semester. Enzymes can go out of the pancreas, and then it goes to the left lung, because it's more directly under the left lung. And then that causes your pleural effusion. DIC, we talked about. Shock. Renal failure, because you're third spacing and your kidneys need massively perfused. And if you're hypovolemic, your kidneys aren't being perfused. And so that will cause renal failure. And then hypocalcemia, like we said, it likes to combine to calcium. It has nowhere else to go. So then your calcium's low. Risk factors. If you have gallstones, it's a blockage of some type. That's a risk factor. Other tumors or cysts. You can, like alcoholism is a big one. I have it circled. If different drugs, toxicities, cystic fibrosis, they have all those extra secretions. The pancreas is so very determined by that. Trauma, different disorders, tobacco, HIV, clinical manifestations. So it's just dependent on the severity. Some people don't know they have it. Some people know they have it. So it just depends. Some people are nauseous. You give them medications for nausea. It can be a sudden onset. And then it also has here, it can radiate to your back. So just like other things we've seen can like radiate to a shoulder, it can radiate to your back. And you can also have flank pain and shoulder pain as well. So jaundice, they're having a buildup of that urea. And then they can have like a blue-gray discoloration, decreased bowel sounds, decreased BP, tachycardia, kind of like shock. You're losing your blood. It's not coming back to your heart. So your heart rate's going to be down, but you're going to try and compensate with that increased heart rate. Left perfusion, you're going to hear all those crackles. You can have a fever. So put these people on NPO, usually. Pain control. Imagine your pancreas eating itself. Like, that's terrifying. I'm sure it's very painful. And then because they're tachycardia, you can try and control with different like heart meds, give them fluids, stuff like that. So again, look at your labs. Amylase, lipase are your two most common. And then you're going to have calcium and magnesium. I know she has here levels, but I wrote down calcium like the 8 to 10 point or to 10, and then mag like 1.5 to 2.5. I know there's been in my semester there's confusion about which levels she wants us to use. I'm sure she's told you by now. Stick with these levels: bilirubin, albumin, glucose. So think about what the pancreas does and how these labs connect. Amylase, lipase, they're produced in the liver. If it can't get out of the liver, it's going to be high. Calcium and magnesium, low, because it says due to fat necrosis, but when, like we said, when it can't get out, it likes to bind to calcium, so it's low. Bilirubin, high. Albumin is low because you produce it in your liver. Why am I thinking low? Protein, third spacing. Oh, okay. So it just talks about like the protein, how it is metabolized, and since it's not working, it's going to be low. That makes sense. Because you take your protein and you put it into albumin, and if your pancreas isn't working, you can't make that transition. You're not producing those other enzymes to break down that protein and produce albumin, so it's going to be low. Glucose is high. It's that whole decreased insulin when your pancreas isn't working. You get insulin from your pancreas, so your glucose is going to be high if you can't produce that insulin. And then imaging. So CT, always, like we've always said, get a CT scan. Ultrasound can be a good indicator if there's like a gallstone or if there's any other kind of tumor. X-ray, really, you can't see anything wrong, so there's no reason to get an X-ray. You can do like an abdominal X-ray, I guess, but it's basically just going to show you like abscesses. If it's something that's not a tumor, then you're really not going to see anything. And then they have the ERCP, and that is for bleeding. Especially you can look at the different. It says diagnosis of pancreatic stones or removal of gallstones, but really you can just look at, I have here bleeding and how it is affected in the pancreas as well. You can like get a good look at the area, how much blood you're losing, stuff like that. So diagnosis, so there's a lot of diagnoses with this. So you have decreased GI activity and pancreas stimulation. You can put them on NPO. This is like acute pain and inadequate nutrition is the two labels that she has. But you put them on NPO. Sometimes they might need NG, and then NG suction. You don't want them to have to break down food, right? That's the whole reason that their liver isn't working. They're not being able to break down food. So don't give them food that they can't break down. Sometimes you can give them like TPN. It just depends on how severe it is, really. You can give them IV meds. Position them. They like to be positioned in the fetal position. It must be comfortable. They're in a lot of pain. Like I said, TPN, small frequent meals. You're going to... This one, don't give them like spicy foods. No GI stimulus, so don't give them chocolate or coffee. I would die without chocolate, but don't give them chocolate. No alcohol. This one says high protein, low fat. So like with the liver, we said low protein, but this one, we want a high protein, low fat. So kind of the opposite. Collaborative care, look at hydration. You want to know you're going to want to do IV maintenance fluids, emergency treatment for shock, replace that mag and calcium with IV replacements, observe for signs and symptoms of hypocalcemia. So like you're going to seizures, like that overactive cell membrane. Serum glucose could be over 300 because you're not producing insulin. So you're going to want to give them insulin. Administer plasma, albumin. Think about what your pancreas does. It does a lot for your GI. So think about how it's not working and what interventions you're going to do. You can do surgical interventions, and then you can also drain like different abscesses, and that will help excrete those enzymes as well. So incidence. So a pancreatic attack is more common with alcoholism. So you might see on a holiday if you're working Christmas, or if it's like someone was on vacation and they're getting a lot of alcohol, then they're going to come into Did you bring me? Don't do that. I'm almost done. Thanks, Mom. She brought me grilled cheese. But vacation, holiday, you're going to see people come in with an attack because they've been drinking a lot. Death can occur with acute pancreatitis, increased fat, decreased protein, no spicy, no alcohol, no chocolate, no caffeine. Chronic pancreatitis is that one that's been happening for a really long time. They might have been alcoholic for 50 years. Yeah, your liver and your pancreas are pretty much shot. It can go into remission and exacerbation. The categories can be chronic calcifying pancreatitis. That's related to alcoholism. I don't know why I said it like that, alcoholism. Enzymes and proteins, they make a plug in that duct, and then it increases the pancreas in the firmness and decreases the function. So we've been talking about like it's eating itself. Sometimes the pancreas becomes like hardened, firm, and then it won't release any of those enzymes as well. If it's not being absorbed into the small intestine, and it's not being used, the levels are going to be high. But if you're not producing the levels because it's firm and you can't get them out, then your levels are going to be low. Just think about like what's happening in the pancreas. Usually your levels are going to be high with pancreatitis. They're going to be malnourished. Their stool will be like foul odor, liquidy, because they're not breaking down that food correctly. You can put them on the vitamins that they need, enzymes. Like some people have gotten, certain procedures done where they have to eat, where they have to take enzymes when they eat food so that it can be broken down. So loss of the exocrine function, that is, it can be attributed like weight loss can happen. The pain, basically the same stuff that we've been talking about, but the malabsorption is the big one because you have decreased pancreatic secretions. Loss of endocrine function is that developing of diabetes in the end because they're not producing insulin, which I know it sounds weird to think about it this way, but like type 1 diabetics don't produce insulin, so they're getting it constantly. Type 2s produce insulin, but they have so much fat on top of their receptors that the insulin isn't working. So it's not that these people are obese or like would look like your normal type 2 diabetic necessarily. Their pancreas might just be shot, and you might have to treat them kind of like a type 1 where you just give them insulin. We all know that if you have like pancreatitis, hepatitis, stuff like that, you probably have other chronic conditions. So I'm not saying like judge anybody. I'm just saying like it might not be what you think it is. So enzyme replacement, like we said, nutrition, you want them on a diet of 4,000 to 6,000 calories a day. There's no way I could eat that much. I snack right now and there's no way I can eat that much. Low fat, high carb, high protein. No alcohol whatsoever. She does have a table here on page 1225 is table 59.4. And then surgical, there's really nothing that can be done surgically for some of these people. And then it just says, final note, that all patients with acute or chronic pancreatitis will be more likely to develop diabetes and or pancreatic cancer. Must abstain from alcohol, and there will be a lifetime of chronic illnesses and just interventions that they're going to have to, like lifestyle modifications. And then I will do my obstructive bowel one after I eat food.